Welcome to our webinar titled 2023 EHA and ASCO MDS AML Update. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors, Amogen, Alexion, Apellis, Merck, and Tahoe Oncology, and the generous support of our patients, families, and caregivers for supporting the webinar today. Before we get started with the webinar, I'd like to let you know about a few educational opportunities that may be of interest to you. We have 2 patient and family conferences left this year. Our next conference is actually this Saturday in New Haven, Connecticut. And our last conference will be on November the 4th in Dallas, Texas. Registration is open for both of these conferences. If you cannot join us in person, you can join us virtually and still have the experience of hearing all of the presentations from our wonderful group of speakers that will be at each. We also have support groups, which are held monthly. We currently have 10 virtual support groups. The support groups span from aplastic anemia groups, MDS groups, transplant groups. We also have a family and caregiver support group. They're held monthly, and to find out more about the support groups and for registration, you can visit our website at aamds.org. Once you register, you will receive a confirmation email with the login information to participate in the group of your choice. So let's get started with the webinar. After the presentation, there will be a question and answer session. If you would like to submit a question or a comment, you can do so by using the Q&A icon in the engagement panel on your right. Just type in the Q&A text box window, just hit enter, and we'll do our best to get to everyone's questions today. I do ask that you do 2 things to help me manage all of the incoming questions. First, submit your entire question all at the same time. It's very difficult to try to piece together questions. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Our specialist today is Dr. Catherine Lai, who is an associate professor and the physician leader of the Leukemia Clinic Research Unit at the University of Penn's Perelman Center for Advanced Medicine. She is board certified in hematology, oncology, and internal medicine. She specializes in detecting, monitoring, and treating acute leukemias and myeloid malignancies in adults. She previously was with the National Institutes of Health and the MedStar General University of Hospital, where she focused on clinical trials in acute leukemias. Her research focus is on novel therapeutics, designing and conducting clinical trials and health outcomes for leukemia and myeloid malignancy patients. It's my extreme pleasure to welcome Dr. Lai.
Hi, everybody. Thanks, Lee. I'm really excited to be here. I'm really passionate about education and feel that that patients and family members who are educated can ask better questions to maximize treatment options. So with that, let's get started. Okay, so as mentioned, I'll be going over the ASCO and EHA updates in AML and MDS. It's a very large topic, so I tried to select the most relevant. That being said, if there's something of particular interest, happy to answer that question if you put it in the chat. Also, just to put us on the same page, there are some general information slides, as well as reviewing some updated classifications that have occurred within the last year. These are my disclosures. Okay, so let's start off with the basics, which most of you probably already know, but just in case you don't, what is bone marrow? Bone marrow is one of our organs. It's in the middle of our bones, so not the surface bones that you can feel, but very deep in the inside. It is responsible for your red blood cells, which makes our hemoglobin, which we need to carry oxygen to our body so that we can live. It's responsible for our white blood cells, which is different parts of our immune system, which we need to fight infection. And then lastly, for our platelets, which we need so that when we cut ourselves, we don't bruise or bleed too much. So what happens in the bone marrow during normal circumstances, in which we call normal hematopoiesis? And so what happens is we have at the center, we have at the very top this hematopoietic stem cell, which is, the analogy would be similar to like an embryo where you haven't yet developed. And what happens is that along the normal pathway, it develops into its specific function. So first we develop into our myeloid as compared to lymphoid, which correlates to which path becomes abnormal, which specific type of leukemia you have. The myeloid is responsible for those things that I mentioned, the megakaryocyte, which becomes our platelets, the erythrocyte are the red blood cells, which we need for our hemoglobin, and then the myeloblast, which is an early development, is our white cell, which again becomes different parts of our immune system. Specifically, you can see the neutrophil, the one with the funny lobes here, is the one that's responsible for fighting against bacterial infections. So often you might hear the word neutropenic, and that's because your neutrophil count is low and you're more susceptible to bacterial infections. On the right, the lymphoid progenitor, these make up our lymphocytes, and those more predominantly are important for fighting against viral infections. So what happens in MDS and AML in this pathway is that this whole myeloid progenitor on the left does not properly differentiate, and those cells do not function normally. So what does that look like in the blood? Here is if we were to take 1 drop of your blood and we were to put it on a slide, which we look at under the microscope, what you can see here is that you see a normal blood on the right and blood with a lot of leukemia blasts representing MDS and or AML, depending on the percentage of blasts. Okay, so what do we see on the normal side? So the thing that makes up the most, which is most abundant, which are your red blood cells, which are all these little light pink things. And so that's, again, all those red blood cells are carrying your oxygen. The larger cells, the larger ones that are larger than your red blood cells, these are components of your white cells. And the really tiny ones, these tiny little ones here, those are your platelets. Okay, now what do we see on the right? We see all these are what we call blasts. You can see that, again, they're much larger than the normal red blood cell, but they're also much more, what I say, angry looking, and so therefore sticky, and they're sticking together, and they're preventing the other cells from being able to work normally and kind of flow through the system normally. So how I think about this is what happens in a normal system. Think of it, different cars moving along different highways and traffic patterns, and there's no traffic jam. And when you get an overgrowth of these abnormal cells or these blasts, they're now causing congestion, and that congestion is causing strain on your organs. The other analogy I like to give a lot to a lot of my patients is that a normal bone marrow is like a flower garden represented by 3 different types of flowers. So I say daisies for your immune system, roses for your red blood cells, and tulips for your platelets. And so what happens in a bone marrow with MDS or with AML is that it happens on the right, which is that you have a garden which has been invaded by weeds. As we know, weeds prevent our normal flowers from growing, which is why oftentimes patients are presenting with very low counts, because the normal flowers aren't able to grow and produce normally, and that's typically what causes the symptoms of fatigue because your energy level was low, or bruising or bleeding because your platelet count is low, or infections because your white blood cell count is low. And then chemotherapy is like weeding the garden. We remove all the weeds. Unfortunately, chemo isn't so specific that we're only able to pick out the weeds. Typically, we pull out the weeds and some of the flowers in the process. We all know that when you pull weeds, you leave holes, and that it takes time for your bone marrow to grow back its normal cells and develop flowers. So all that to say is that the process of treatment and all the side effects does take time. So I'm first going to talk about AML, or acute myeloid leukemia. One of the reasons why it is so challenging to treat is because it's very heterogeneous, meaning even though it's under the umbrella of AML, there are kind of multiple diseases within that category. What you're seeing here is different cytogenetic and or molecular abnormalities that can occur within a patient. And so you can have these multiple abnormalities. Some of them have targeted, some of them have not. And because there's so many different combinations, it makes each AML patient very unique. So for example, this circus plot on the right here, each mutation around the circle is a potential mutation that a patient can have at diagnosis. Most patients have more than one mutation. So on average, a patient has 3 mutations. The frequency of the mutation is represented by the width of the arc that's around the circle. So for example, in DNMT3A, this is one of the more commonly occurring mutations. And so this width of the arc is larger than, say, the IDH or the TET2. Now, when we're looking at the combination and the frequency of the combination of mutations, that's represented by the adjoining arc. So again, if we take this DNMT3A mutation, you see that that has a adjoining arc with NPM1, an adjoining arc with FLT3, an adjoining arc with IDH. And so, but these are different widths, saying that the DNMT3A mutation occurs more commonly with NPM1, say, compared to DNMT3A compared to FLT3. And so, and that's just one example, but you have all these other different mutations that are around the circles, and then the combinations. This is why it's been very challenging to develop new treatments in AML. So before we get into treatment, let's also talk about what's happened in terms of our classification, and this specifically is our pathologic classification, meaning what do we see under the microscope in combination with the cytogenetic abnormalities that we see that contributes to how we subclassify your AML. There are now 2 different classification schemes. One is the World Health Organization. The other one is the International Consensus Guidelines. This is a lot of information on the slide. For the most part, the 2 classification symptoms are congruent. What the big change is that there are now certain genetic mutations that if you have this mutation, irrespective of the number of leukemia cells circulating, it now defines you as having AML. So that take-home message, meaning that if you have AML, you should be asking your physician about, or your care team about, what are your molecular or cytogenetic abnormalities and how does that relate to your AML? The other thing is that there are different mutations that occur that's represented by the overlapping Venn diagram. There are some subtle differences between the 2. For the most part, they overlap. But again, this is looking at the different cytogenetic and molecular abnormalities that a patient has. We then take this information and we put it into a risk stratification. So we take all your information in terms of what we see under the microscope and what your molecular abnormalities show, and then we put it into this European Leukemia Network. This was updated in 2022. Prior to this, it was updated in 2017. And you go into one of 3 different categories. favorable, intermediate, or adverse risk. I've never really liked the term favorable because favorable and leukemia seem counterintuitive. But in general, this is to show you that there are slightly different changes from 2017 on the left compared to 2022 on the right. For the most part, the favorable risk patients are patients who have particular mutations called core binding factor or a mutation with NPM1. These patients, if they are eligible and fit enough to receive intensive chemotherapy, do very well with intensive chemotherapy and can potentially be cured with chemotherapy alone. And these are the patients that we are often not saying need to go to transplant. The intermediate risk group and the adverse risk group, these are the patients that have a higher risk of relapse. So the adverse risk patients, for those who are eligible, we recommend them going to transplant. And for the intermediate risk group, I would say at least 50% of these patients are often recommended for transplant. What, again, all these different numbers and letters are meaning are these different things that your team and your oncologist is looking at in terms of which mutation that you have to put you into a specific category to help with both short-term planning and long-term planning. So what your immediate treatment is going to be to get you into remission, and then what your long-term treatment is going to be, or your long-term plan is to prevent your leukemia from coming back. Some of these have targets. For example, FLT3 mutations we have drugs now that are approved that can be added to chemotherapy. There are some other ones not on here too that I'll get into, but it's the combination of the mutations that you have which puts you into a specific risk group. So I'm just going to go over the VIALE-A trial because the VIALE-A trial has really transformed how we treat our AML patients who are unfit for intensive chemotherapy. This was a regimen, that has been around now since 2017. And so we have long-term follow-up now to say that the combination of azacitidine plus venetoclax is superior to azacitidine alone, which was the previous. So one drug as opposed to two. This two drug is now kind of the standard for patients who can't tolerate intensive chemotherapy. What you're seeing in the red box is showing the different mutations and showing that some mutations respond more favorably than others. However, in general, all the mutations tend to respond better when two drugs are given as opposed to one. But in particular, the IDH, we know the IDH mutations are particularly sensitive to venetoclax. And while this is an ASCO and EHA update, this was the long-term follow-up, which was presented as an oral at ASH, which I just wanted to show because this is the long-term follow-up. You're seeing now a median follow-up time of 43 months. And what you're seeing is still a separation of the curves with the patients who received two drugs on the blue or on the top and the patients who only received one drug on the bottom. And the fact that the blue line is higher is showing that these patients are living longer compared to the blue line. The double drugs is doing better than the single drugs. And this is going even out to 43 months. So the other way to think about this, though, is that we're not curing patients with just chemotherapy alone, and that we still need, so while we've made a lot of progress, we still need, we can always do better. The other thing which is unique to this regimen is if we apply I know I just went over applying, the risk stratification classification, if you're favorable, intermediate, or adverse risk. Those categories are typically for patients, helps with treatment for patients who receive induction chemotherapy. When we try to apply this risk stratification scheme to patients who receive Aza-Ven, it's harder to determine who is going to respond and who is not going to respond. And so essentially, this study that's looked at, instead of making it complicated with trying to remember all those different mutations and which ones you have and which one is favorable, intermediate, or poor risk, this study separated benefit of azacitidine venetoclax into this kind of simple scoring or simple scheme based on the presence or absence of 3 different mutations: a P53 mutation, a FLT3 mutation, and RAS mutations. In general, P53 mutated patients tend to be very chemo resistant to all treatment. And so these are the patients that, if you have a P53 mutated patient, we still treat with azacitidine plus venetoclax, but are less likely to benefit. And that's shown by this blue line here. This is their survival curve. So the one on the bottom is the patients who had a median survival of 6 months. If you don't have a P53 wild type, but you have a FLT3 or a RAS mutation, your median overall survival is 12 months, as represented in the green line. And the patients that were most likely to have the longest benefit, with a median overall survival of more than 24 months, had no FLT3, no RAS, and no P53 wild type. So we're now better able to predict how likely a patient is to respond and for how much longer. Okay, so we have a lot of treatment that is 2-drug therapy, but a lot of what has come out of a lot of the different meetings recently is more treatment better. So should we be thinking about triplets versus doublets? I would say in general, there are different pros and cons to both. Triplets are more therapy, so it's more toxic, but potentially you're getting a higher response or deeper level of response. And so is that translating to more survival? Or is it okay to do doublet and then sequence the doublets in a different way? We still don't know the answer, but more to come. So a lot has changed in the last handful of years, which is fantastic. Again, just to put everybody on the same page, I've created some slides here. What this shows is that the green represents regimens that are currently FDA approved, and the red represents regimens that have been presented at recent meetings, and that look very promising based on the mechanism of action. So for this particular slide, I put in here mutation agnostic, meaning that for patients who don't have a specific mutation where we have a known targeted agent to apply to that patient population, the current standard of care with 2-drug therapies is our traditional standard 7 and 3, or cytarabine plus an anthracycline, for those fit enough to receive induction chemotherapy. We have the study I just mentioned, the venetoclax plus azacitidine or decitabine. This is for patients who typically are not fit enough to receive intensive chemotherapy. We also have CPX-351, which is actually, it's 2 drugs packaged into 1 molecule. And then we also have venetoclax with a different low intensity care therapy called low-dose cytarabine. So all of these, they're green. That means they're currently FDA approved. So 2 drugs for patients who don't have a particular target mutation. Now here, these triplets, these are different agents which have shown some promise. So magrolimab is a anti-CD47 antibody, which has been used in combination with azacitidine venetoclax. We also have PVEC, which is an anti-CD123 antibody drug conjugate. So in both the situation of PVEC and magrolimab, this is using an immune-based therapy in combination with our chemotherapies. So novel ways to introduce a third drug. FLAG-IDA is chemo plus an oral agent venetoclax. And then also cladribine, which is chemo plus low-dose cytarabine plus venetoclax. So 3 kind of different chemo regimens. Okay, so these were all that I thought that, even though this was from ASH, these were the drugs that I thought were very exciting in terms of, or the studies that were exciting, but in the interest of time and wanting to go over ASCO and EHA stuff, I just summarized it here. So magrolimab, PVEC, I don't have time to go into this, but there's also another immune-based therapy that uses an anti-CD33 antibody in combination with chemo. And then in addition to things that don't work, I think it's always important to bring up things that don't work. So So sabatolimab, which is a TIM-3 inhibitor, was not effective, and nivolumab, which is commonly used in solid tumors, was not effective in this particular regimen at preventing relapse. So now let's go into for FLT3 mutated. So if you have a FLT3 mutated AML, the current doublet, which is approved, is venetoclax plus azacitidine, which we've talked about. And the current triplet, which is approved, is 7+3 plus midostaurin. And I'm just realizing I forgot to color. So there's actually two. I take that back. 7+3 plus quizartinib, that was also recently approved this summer. So we now have two different FLT3 inhibitors, which we can add to our chemotherapy backbone to be able to use against FLT3 mutated disease. Other big studies that have shown a lot of promise are other triplets include 7+3 plus gilteritinib, another FLT3 inhibitor, 7+3 plus crenolinib, another FLT3 inhibitor, and then the triplet, which is venetoclax plus azacitidine plus gilteritinib. And if you have any specific questions, again, put them in the chat. I'm happy to answer them in the Q&A session. So why is FLT3 mutated disease so bad? In particular, FLT3 AML has a high risk of relapse, and so these patients are referred for bone marrow transplant. In the last handful of years, there's been a lot of research that's gone into what's called measurable residual disease, or MRD. And we know if you have MRD or measurable residual disease before you go to transplant, there's a much higher risk of relapse as opposed to if you can become MRD negative before. There have been other studies that show that FLT3 inhibitors can be given after transplant as maintenance to prevent disease from coming back. And gilteritinib, which is not yet approved, but is an oral potent FLT3 inhibitor, is not approved in the newly diagnosed setting, but is approved in the relapse setting, is very well tolerated. So one of the studies that was presented at EHA was this Morpho study, which did look at gilteritinib in patients who were going to transplant and were randomized. So if you focus on the bottom here, after transplant, they either received gilteritinib or placebo for 24 months of maintenance, and we looked at outcomes. So what did they see? So in general, these are survival curves. So looking at the likelihood of survival over time. And what they saw was that if you were MRD positive, so on the left here, when they looked at relapse-free survival, so how long were you able to go before your leukemia came back? If you were MRD positive and you took gilteritinib compared to placebo, your probability of survival was significantly higher than if you didn't. If you are MRD negative, the gilteritinib curve is still above the placebo curve, but these lines are close together and it's not statistically significant. So less of a benefit if you're MRD negative in terms of relapse-free survival, but definitely if you're MRD positive, there was a benefit. They also looked at the effect of conditioning, meaning the chemotherapy that you get before your transplant. And for patients who were able to receive a myeloablative, so a more intensive conditioning regimen compared to a reduced intensity, so MAC versus RIC, and reduced intensity is just a lower intensity, typically for older patients, that the MAC therapy or the myeloablative therapy did improve overall survival. And that was the case whether or not patients were MRD positive versus MRD negative. This is likely because the conditioning regimen, while the purpose of this is to get rid of the patient's immune system before the new immune system takes over, there's thought that the chemotherapy, because of its higher intensity, can eradicate any minimal disease that's still there. So now moving on, just to there's another target called IDH1 or IDH2. There are doublets that are FDA approved in this situation. We have our standard 7 and 3, venetoclax plus azacitidine, also ivosidenib, which is an IDH1 inhibitor plus azacitidine, is also FDA approved. Enasidenib plus azacitidine, which is an IDH2 inhibitor plus azacitidine, is not FDA approved, but there is data showing its efficacy. Then other triplets that have studies but have not yet been FDA approved or are not FDA approved is our traditional 7 and 3 backbone, so chemotherapy backbone plus an IDH inhibitor, or venetoclax plus aza plus an IDH inhibitor backbone. Okay, also moving on to something that was presented at EHA. So one thing that we have not previously had a targeted agent for is a particular mutation called NPM1. This occurs in about 30% of AML patients, so a good amount of patients. These often have co-mutations. When it's just NPM1 mutation by itself, this has a high likelihood of having a good outcome, but when you have a mutation, multiple mutations, there's a higher risk for relapse. So there is now a drug called, it's a menin inhibitor, and this one specifically is called ziftomenib, which targets the menin pathway, of which where the NPM1 mutation sits. And so by inhibiting this, specifically this NPM1, it also inhibits our KMT2A, but the focus of the study at EHA was on NPM1. You then are preventing proliferation for that specific leukemia population. So this study showed that ziftomenib by itself, monotherapy, had a durable response. This is something called a swimmer's plot. It looks like swimmers in a lane, and the horizontal line represents how long a patient responded. The color coding is represented, it represents the dose. The star represents the point at which a patient went into complete remission. What type of complete remission, either CR or CRI. And then here on the right is showing PD is for progressive disease. But what you're seeing is that there are patients who had a durable response. So they're able to remain on therapy for a long time before they progressed. Okay, now let's switch to MDS. So in terms of diagnosis of MDS, there are several things that we have to take into consideration. It's your cytopenias, so are your blood counts low? And then also what we see under the microscope, do we see blasts or not? Or do we see abnormalities, mutation abnormalities that are typically seen in MDS? And it's very important that you also exclude other reasons that can be correctable, like a vitamin deficiency, alcohol abuse, medications, other syndromes. The other thing, this classification scheme as in AML was also updated in MDS. All that to say that there are now different cutoffs in terms of blast burden, in terms of how we subcategorize MDS, and also other specific mutations that you can have, which are disease defining, with such as your SF3B1 mutation and your P53, as well as our 5q, which was already previously known. What do we do with all this information? We take your blood counts in addition to your cytogenetics and your bone marrow blast percentage, and we put this into a risk score, which helps us predict how long a patient might live or what the likelihood is of progressing to AML. What's new in the last year or so is that we now have a new classification system called IPSS-M. So it takes all those things I just mentioned in addition to your different mutations that you have that wasn't previously incorporated, and then it helps give us a more accurate prediction of leukemia-free survival, overall survival, and likelihood of transformation to AML. There are also different calculators which you can use. So you can, if you want to calculate your score, or you can ask your physician, what does your score mean? And so essentially, depending on what your score is, so I think of it as a scale 1 to 5, low to high. Our high-risk patients are the patients we're recommending for chemo. Our low-risk patients are the ones that we're typically watching. And this is the likelihood of survival. Now, the caveat to this is that this is for patients who have not received any treatment. And so now that we do have treatment for AML, now that we do have treatment for MDS and our treatments are improving, I would say in general, all these survival curves are improved. So we have to take that with a grain of salt. We also know that depending on the type of mutation you have, that helps in terms of being favorable or not. So the SF3B1 mutation, which is also, there's a particular drug, luspatercept, which I'll be talking about. That one is a favorable mutation. Black is neutral, and red has a poor, a negative or poor prognostic. So again, take home being is that when you're diagnosed, or if you're diagnosed with MDS, it's important to ask your oncologist about the genetic makeup and what specific mutations you have, so that you can help risk stratify you and help aid in the type of treatment that you might receive. We also know that the number of mutations predicts survival and risk for transformation. All this to say is that the more mutations you have, the higher likelihood of transformation and also lower survival. But it also depends on your risk status, so whether or not you're low risk or high risk. So a lot of different factors. I know it makes the landscape very complicating. Okay, so now let's go on to some of the studies that were presented at ASCO, which I think were very exciting. So the COMMAND study, which was a phase 3 international trial that compared efficacy and safety of luspatercept versus our standard EPO-alpha or erythroid stimulating agents for the treatment of anemia in patients who were low risk MDS, for patients who were ESA naive, so never having received any therapy, who required red blood cell transfusions. Luspatercept it binds transforming growth factor, and it reduces something called SMAD signaling. And so it enhances your red blood cell production in a different way than EPO typically does. So how I think of it is, it's not chemotherapy. If you were to think about the cells, the ones that are supposed to be making the blood, ESAs stimulate let's call it a red flag on your blood cells, and luspatercept stimulates a blue flag. So they have different mechanisms that are not supposed to compete, but they work in different ways. Okay, so what do we see here? So the primary endpoint was that they looked at transfusion independence after 12 weeks, and they also looked for, did your hemoglobin increase? And what you're seeing on the left here is that you're seeing that about 60% of the patient compared to 30% of the patient, excuse me, met the primary endpoint. And that when they looked at the breakdown of different things, looking at your baseline EPO level, which is a marker in your blood, looking at your baseline transfusion burden, your ring sideroblast status, and also your SF3B1 status, that the patients who received luspatercept did do better compared to the patients who received ESAs. This was presented at ASCO. It was published in the Lancet in June, and it was recently FDA approved in August for these patients. Whereas the previous approval, just so you know, was for patients who had anemia after they had already been treated with an ESA. And specifically, it was for patients who had ring sideroblast or this SF3B1 mutation. So now the label is expanded and can treat a larger patient population. So the next study that was presented at ASCO was called atelmastat, which it's a telomerase inhibitor, which causes apoptosis, which essentially means it causes those cells to explode and die, for lack of a better terms. And this looked at your red blood cell transfusion independence in responders compared to non-responders who received placebo. And so what you're seeing here is that the patients who received atelmastat in blue compared to the placebo in yellow had a much higher rate of a transfusion independence after 8 weeks. Here you can see that the median duration of transfusion independence for atelmastat was 52 weeks compared to 13 weeks. And so this was highly significant. Okay, so I'll wrap here and leave plenty of time for questions. And that my take-home message again is that if we're comparing a normal marrow to a bone marrow with AML or MDS, that we need to know the types of leads in the garden, specifically what molecular abnormalities are present, what mutations are driving the disease burden. Is there a particular mutation with a targeted agent that I can take? We want to use appropriate weed killer, meaning we want to tailor our treatment to individual genetic profiles and physiologic function. So I know, excuse me, we talked a lot about treatment, but I also think it's really important to look at physiologic function, meaning not just looking at chronologic age, but looking at the health of the whole patient, because that does affect survival outcomes. And then we also want to understand our optimal conditions for growth. Specifically, how do we approach therapy in our older patients based on the toxicity and what they can tolerate. And with that, I thank you very much, and I'm happy to take any questions.
Thank you so much, Dr. Lai. We have a few questions for you. The first question is actually a two-part. So the first is luspatercept considered an ESA?
So that's a good question. So it is not. It is. It's a different mechanism. It binds. It binds to a different receptor. So again, if we think of the drug, the ESA, as stimulating a particular point on the red blood cell, the example was that it stimulates a certain red flag to say make more red blood cells, and luspatercept stimulates the blue flag on the other side to say make more red blood cells.
Thank you. And the reason for the question is this patient has tried Aranesp. It worked for a little while and stopped working, and now they're transfusion dependent. So they were wondering, the question is, would there be any reason if Aranesp did not work for a patient to try luspatercept?
Yes, it's reasonable to try luspatercept. In the patients for who have failed after an ESA, it used to only be for patients with a particular mutation, the SF3B1 or the ring sideroblast. However, there is data to support that it is effective in patients with other mutations, as represented by that command study. And also now that luspatercept is FDA approved for patients even before they receive an ESA, it's possible that they might respond to luspatercept. So definitely worth having a conversation with their oncologist about trying luspatercept.
Great. Thank you so much for that. This question comes from a newly diagnosed patient, and it's being suggested that this patient use Vidasa, a single agent. They're wondering, does the data support using a combination therapy may be better than using single therapy?
Does it say if it's AML versus MDS?
MDS.
Okay, so the standard of care currently for MDS is single agent. All the data that I was talking about with the combination of drugs was for AML or acute myeloid leukemia. That being said, unless there was interest in clinical trial in which you could do Vidasa plus an additional agent, but in a patient who has MDS, who has a higher risk, who needs to start chemotherapy, Vidasa would be, the standard of choice. For a patient, there is some data for MDS patients with Vidasa and venetoclax. That's not standard of care. It's not FDA approved. It is helpful at decreasing blast burden. It causes a lot more side effects, particularly cytopenias. And so I'm typically using it for the patients who are younger, who are going to transplant, where I'm trying to use it as a bridge, but not in general across the board for my older patients with MDS.
Thank you so much for that. Our next question is about classifications. is there any benefit for a patient being reclassified if their disease is changing? Do you go through that genetic testing? I guess the question is, if you're being treated and they feel the disease is changing.
Yeah, that's a really good question. So in a purist form, the classification scheme is only helpful at predicting survival when you're initially diagnosed. That being said, it is very important that every time you're repeating a bone marrow biopsy, because you're concerned about progression or evolution, is that all the genetic testing is done. That's not for the purposes of reclassifying, but it's for the purposes of helping to determine short-term and long-term goals, to see if there's a targeted agent, and to see if you're more or less likely to respond to certain agents. It also tells you about the natural history of the disease and what might happen. So it gives very useful information to your oncologist and to yourself, in terms of kind of the type of disease that is evolving. But you can't apply the same classification, because that initial classification, what they did, how they created that classification system, is that they took hundreds of MDS patients who had never received any treatment, and they looked at what class they were, low to high, and they followed them out to see how long they lived. So that's why, and those patients were never reclassified, which is why you technically can't reclassify it. We do know that if you acquire a mutation that puts you at higher risk, you have more likely to have aggressive disease, but you can't truly use it in terms of how long somebody might live.
Thank you. Our next question comes from a patient who has been using Dacogen for the last 3 years. It appears that the treatment may no longer be working as effectively. They'd like to know, is there any data to support possibly switching to Incovi, or
Yeah, that's a good question. So in general, just for the rest of the audience, Dacogen and decitabine are the same. They're, decitabine is the generic name, and Dacogen is the, all drugs have 2 names. Incovi is, so let me back up a little bit. So decitabine or Dacogen comes in 2 forms, IV and oral. The oral version of decitabine is Incovi. The way, even though, so if you look at it, Incovi is technically 2 drugs, but only one of them is chemo. So the way that they were able to make the oral drug effective, oral decitabine is effective, is they linked it with cetirizine, which is is essentially like a linker that allows the metabolism so that you can process the decitabine and it becomes active in the body. So Incovi and decitabine are the same thing. So it wouldn't make sense to switch from Dacogen or decitabine to Incovi. Now, that being said, so azacitidine comes in 2 forms, sub-Q and IV. Decitabine is 5 days, azacitidine is 7 days. They're similar in terms of the mechanism of action, is essentially is very close to each other. They're cousins of each other. There are some patients, there's no way to predict which ones, who, when you switch from one to the other, they might benefit from switching. It's usually azacitidine and decitabine, but I've had patients go in both directions. So it's worth having a conversation with your oncologist about switching. You could also bring up whether or not that particular, whether or not you'd be a candidate to add venetoclax in. There's multiple factors that would go into it, so it would need to be a discussion with your oncologist.
Thank you. Is there a process of switching from Vidasa and Dacogen?
It would be your oncologist would be the one to write it, so you'd have to have a conversation with them about, is that a possibility, why it would or wouldn't work for that particular patient.
Okay, thank you for that. Our next question is, At what point should at what point should a patient consider transplant?
That's a good question. Is that for MDS or AML or for both?
It does not say, so maybe
Okay.
would it be okay to give an answer for both?
Yep, absolutely.
Okay, thank you.
So let's go. So for our AML patients, the adverse risk patients, we ideally go to transplant. Intermediate risk, I would say probably at least 50% of them we recommend for transplant. Now, not every person can be eligible for transplant. You have to be, okay, and so for MDS, it's usually the intermediate and high risk patient, intermediate high and high risk patients, which we're recommending for transplant. The reason why we're recommending transplant in either MDS or AML is because when they're in those higher risk categories, there's a higher risk for relapse, meaning that chemotherapy works, but it's only going to work temporarily. And if you are on treatment long enough or you stop treatment, the disease will come back. So the only way to potentially get rid of the disease is a new bone marrow, which a new bone marrow is a new immune system. So if we go back to the flower garden analogy, a bone marrow transplant is like replacing the soil. Because if chemotherapy is weeding, it doesn't get down to the deep roots, but the transplant can potentially do that. Okay, so but who is eligible for transplant? That is, it depends on the transplant center. It depends on the fitness of patients. So patients typically have to be fit enough to be able to tolerate it, so be able to walk, have their medical issues under control. The age cutoff is 70 plus or minus. That being said, our center has transplanted patients over 70 and has not transplanted patients under 70. So it's not a strict cutoff, but you look at the whole patient in terms of what we think they'll be able to tolerate, who the donor is, all sorts of things.
Thank you. Our next question is, are you aware of any studies looking into the reasons why patients develop MDS? It says, meaning, as an example, looking into patients who may have been exposed to toxins throughout their life.
That's a really good question. So in general, we know that there are certain toxins or amounts of toxins that cause MDS or AML. The ones that are known are massive doses of radiation or chemicals, things on the order of like Chernobyl and Hiroshima, those sorts of things. We also know that there are treatment-related MDSs and AML. So there are patients who have a solid tumor, breast cancer, lymphoma, who receive certain types of chemotherapy or certain types of radiation, which predispose them to MDS or AML. At the time of diagnosing that other cancer, you need the other chemotherapy and the other radiation to cure that cancer. But there is a risk that you develop other complications such as MDS and AML. When we're talking about other exposures, pesticides, burn pits, those things, there hasn't been a strong correlation, but there, at least in the pesticides, the burn pits for a different type of leukemia is being investigated. Then there's also hereditary causes. So whether or not you have a specific mutation that predisposes you, that is something that I think is growing as a field in terms of the technology to detect certain types of hereditary mutations is also evolving. So that's something that also can be a discussion with your oncologist about the specific exposure. So for all my new patients, the questions that I always ask my patients are, where were you born? Where did you grow up? Have you traveled abroad, lived abroad? And where military exposure and what you do for a living. So those are things. So if there's a particular one of those questions that maybe hasn't been discussed, you could bring that up and ask if that is potentially at all related to your MDS or AML.
Well, thank you so much, Dr. Lai, for sharing your time and your expertise with all of us today. If you'd like to watch this webinar again at a later time, it will be available on the platform within the next hour. You can access the recording by navigating the on-demand tab at the top of the platform. It'll also be available on our website within just a few business days. If you have any additional questions, you can send it to us at any time in 3 ways. Send us an email to help@aamds.org. Give us a call at 800-747-2820, or you can submit a question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 40 years. This concludes our webinar. Thank you, Dr. Lai.
Thanks, everybody.
Take care.